case you haven't heard, DCEs are no longer a thing. It's now been renamed as REACH, which is an acronym for Realizing Equity, Access, and Community Health Model, or as my wife quickly pointed out, it's actually really stands for Reach Right Into Your Wallet. That's what the REACH program is short for. It's just lip service as far as we can tell. Our core concerns that were with DCEs now almost entirely, if not more so, apply to the new ACO REACH model. What I want to do for a few minutes is walk through what's probably most pressing on your minds is what has not changed, what issues that we've been talking about for the last several months are still here. So I want to talk about what has not changed and then spend a few minutes about what has changed, because a few things have changed, but as you'll see at the end of this, nothing nearly enough. So what has not changed? It's still the same core model of introducing middlemen into the middle of traditional Medicare who can profiteer, and just exactly the ways we've been talking about. The risk corridor chart that says how much money they can keep is cut and paste from the risk corridor chart from the DCE model. So the ability of these new REACH plans to retain potentially as much as 40% of what they're capitated at is not changed. Our statement that they can say potentially that they can keep potentially that much is identical with this new model. Also identical with this new model is that CMS will be auto-enrolling people into the REACH entities, whatever they're supposed to be called, REACH model groups. So once again, are unchanged without Medicare members' knowledge, full knowledge or consent, they will be assigned to one of these new programs. And indeed, the current DCEs are largely going to flip into REACH models with a few parameters, but pretty much they'll all just become one of these things. There are no, as best as we can find from reading through the new materials, there are no limits on the size of the model that they produce, no limits on CMS's or CMMI's ability to grow the model, so that as far as we can tell, it's still straight on track for taking over 100% of Medicare by the traditional Medicare by the year 2030. We can't find any limits on the types of companies that can participate in this. So all the same concerns we had are still there. It's still fundamentally a model that's based on no evidence. This is not a pathway that has any evidence for it, despite decades of attempts to do things like this through Medicare Advantage and ACOs and such. So it's just another model that puts profits ahead of patients. It still has grossly inadequate beneficiary protections where people who choose to be in traditional Medicare are being pulled out of that. And still, as far as we can tell, the only way that a member can, that a Medicare person can opt out of a REACH program is like they could with the DCE. They have to change primary care providers. So if you don't like being in REACH, no problem, just change your primary care provider, which was pointed out to me earlier today. That means that by 2030, when everybody is in one of these, there won't be a way to opt out because there won't be any primary care doctors who aren't in it. The guardrails are still not adequate. I mean, not that guardrails would even be the right approach to mitigating the harms of profiteering. So we've learned over decades that whenever CMS tries to install guardrails, if they're effective guardrails, they actually threaten the profiteering. Then the industry just buys a larger truck. So you want to get a better road, not better guardrails. Industry always has the resources to stay ahead of these mitigations and guardrails. And then the last thing that hasn't changed is it makes the claim of being targeted at reducing waste and fragmentation. But as we all know on this call, those are problems that are primarily within the Medicare Advantage program. So it's largely the same. There are some differences with REACH. And there's three that I'll call to you. The first is that it does, in writing, provide more lip service to health equity. So it's giving, actually adjusting the benchmarks for the programs based on serving underserved communities. And it requires the REACH programs to do more reporting on how they reach into the underserved communities. It requires them to develop and implement a plan to address disparities in healthcare. But we don't really see any controls on that. We don't, if anything, I'm worried that that's going to open the door to having them be able to make larger profits off of marginalized communities. It seems unlikely that this is even possible to address health equity. It's a change that the ACO community was really proud of was the increasing the control by providers. So as you probably know, ACOs are required to have at least 75% of their governing board be by providers, in theory, physicians primarily. 75%. The DCEs were developed with only requiring 25% of the board to be managed by, to be staffed by, or to be governed by providers. So ACOs were 75%, DCOs, they dropped provider governance to 25%, and the new REACH model kicks it back up to 75% provider governance. It's really hard to imagine how that changes the business model in any substantive way. It's still wide open to the investment community to be pouring their money into this and expecting a return on investment. So it's 25% or 75% provider governance doesn't really change the fact that these organizations are going to be fully accountable to their investors who are looking for a return on those investments. And then the third change is some of the specifics of the way the financial arrangements are defined and calculated. So the way I read that, it's less financial risk for these new organizations, which means more reliable profits for them. So there's this, the system has a benchmark that they establish for these organizations based on claims data. And then they, like the DCEs, they withhold a percentage of the benchmark that they would be capitating the DCE, now the REACH programs at. They withhold a percentage of that for a quality incentive. The DCEs were withholding 5% for these quality programs, and the ACO community said that was too high. So now instead of withholding 5% for these quality programs, the quality withholds are dropped to 2%, so less risk for the ACOs. The global REACH programs have maximum discounts under the DCE model of 5%, and this is falling now to 3.5%. So again, it's an arcane bit of calculation, but it's again less risk on the side of the REACH model than the DCE model had, and the whole calculation methodology has changed. To us, that looks like pretty much exactly what the ACO community asked for, essentially saying, reduce our risk, pay us more money, and we'll perform better. That's the exact backwards way of how you should set up the financial program. None of what I just blathered on about here about financial methodology does anything to address our real concerns, and actually may wind up, as I said, increasing the profiteering. So they're still paid a monthly capitation, which rewards any gains they can do to inflate their risk scores and any gains they can do to restrict care.